Okay, good afternoon, everyone. I assume you can see the slides. I've put it on for quite some while, so this is the schedule that we're following. Today is the 28th of September. Today, Martijn and Johannes are going to talk about clinical OCT. I'm going to kick you off with a few introductory slides before they start. So let's go to that immediately. Oh no, before I go. I guess I received all of your assignment one. Oh, I have to admit some people. I guess I received all your assignment one, and I must say I was quite impressed with the work that you put in. I haven't graded them yet, but I'm very confident that this will work out fine. So good work already. Um, so as usual, some start questions to get us going. And since the topic of today is OCT, these are the questions that we skipped last time on OCT. So usual recipe, try to collaborate on this. If there's any questions, let me know, and I'll chime in. Okay, guys, let's park the third question for a moment because that is for today not so important. But I would like to discuss question 4 and question 5. So maybe it's a little more efficient to do it in this way. So does anybody know, at least conceptually, how the actual or the depth resolution of an OCT system is determined? Okay, you don't remember that, you neither. Okay, then I guess anybody else who wants to chime in? Okay, I guess not. Okay, then I guess there is not much point in doing the rest of the questions either because they are kind of related. Maybe, so we'll skip the fifth question because that is related, but I'll try to get back to that a little bit in the next few slides then. Maybe question number 6, maybe that is something that we could try to answer. So let's say we have two OCT systems that have completely the same specifications, apart from the fact that one uses a center wavelength at 800 nanometers, so more or less reddish light, and the other one uses a center wavelength at 1300 nanometers, which is in the near infrared, so you can't see that anymore. And so now let's say you want to image two types of tissue. The one is the retina, so the netvlies, the back of your eye, and the other one is the skin. Which so if you could pick one of these systems for one of these applications, can you argue which one you would pick for? So the flat says, okay, you're fast. Used 800 for the retina and the 1300 for the skin, since we would need better resolution for the retina. Yeah, that okay. But now let's say I've engineered it in such a way that the resolution of both systems is the same. Of course, that depends a little bit on the answer of question 4 and 5, but let's say I managed to do that. So basically, the question is, what other consideration than resolution could there be for? It has to do. No, haha, that's not true. You can if you because it. I just told you that it's not the only reason that works. That determines this answer, so you can. Yeah, maybe absorption. Finally, that's yeah, good. That's a good point. So there are two important optical properties that determine what kind of signal you get back. The one is scattering, the other one is absorption. So in which situation do you think absorption is a um, is a bigger hamper? Hampers you more? Yeah, in the case of the retina. Do you know what absorber that is? Not blood vessels. Yeah, the fluid in the eye. Yeah, exactly. And that is. I mean, just like everything is almost 70% water, that is also almost 70% water. So there's a lot of water between where your detector is and where your sample is. In this case, the retina. So in the eye, you would want to use a wavelength that has the least the lowest absorption coefficient for water, and that in this case is 800 nanometer. That has a much lower absorption coefficient than 1300 nanometer. So that is the main reason why we use 800 nanometer at the retina. It also comes as a drawback. Do you remember what the trend for scattering was with wavelength? So if I would compare the scattering coefficient at 800 nanometer and 1300 nanometer. Yeah, that is for the smallest particles, but the trend is the same. So it inversely scales with, so Jan says it's 1 over lambda to the power fourth. That is true for the smallest particles. For particles that are a little bit larger than the exponent will be a little bit less, but still it is a decreasing function of wavelength. So at 1300 nanometers, the scattering will be lower than at 800 nanometers. Which basically means that that you can that if you would use the 1300 nanometer, you could image a little bit deeper because the scattering is lower. So there is this trade-off between the absorption and between this absorption and the scattering contributions, or the absorption and scattering effects on how deep you can image and how much signal you can get back. So you always have to. There's always this trade-off, and for the retina, that trade-off falls in favor of the 800 nanometers. For skin, it would fall in favor of the 1300 nanometer because there is not so much water in the skin, and you would like to look a little bit deeper. So that trade-off is then inherent. Okay, I'm going to skip these for now. So this is what we'll be doing today. In the first block, I'll dwell a little bit more on the questions that I just tried to ask, just to make sure that you're prepared for the next two blocks, which is Martijn de Bruin, who's going to talk about OCT clinically applied in the urology clinic, and Johannes, who you already know, is going to talk about OCT in pulmonology, and I think he has some other applications as well. Okay, so this you know. So we broadly consider OCT as the optical analog of ultrasound imaging. So you can make the same kind of images in 3D as well, of reflectivity as a function of depth or spatial position. But because you use light waves instead of sound waves, you can achieve a much higher resolution. You can resolve much smaller structures. And sometimes people, if they get really bold, they will try to sell OCT as some kind of optical histology. Kind of proof of that is the color image on the bottom. So on the left-hand side, you see an OCT image of an arterial wall. So in a blood vessel of a rat, it's ex vivo, so it's taken out. And on the right-hand side, you see the same thing, but then histology, so a colored coupe under the microscope. And if you're kind, then you can you could acknowledge that you can see the same kind of layering, more or less the same kind of structures in there. So it approaches histology. It is not the same yet, but sometimes we think we can approach histology. Okay, so how does it look like? So this is again a graph that I guess you already saw, where various imaging techniques in the clinic are put on an axis where you have on the horizontal axis depth, so how deep you can image, how deep you can see into tissue, and on the vertical axis the resolution at which you can make these images. And there is a vast array of techniques that ranges from PET to SPECT to MRI to confocal microscopy, and OCT is somewhere on the lower left hand of this graph. So we cannot look so deep, about a millimeter to millimeters max. That's I guess the maximum depth, and then the resolution that you can get is in the order of 1 to 10 micrometers. So it fills a kind of nice niche in this whole spectrum of imaging techniques. In OCT, the imaging resolution is determined mainly by the technical characteristics of the system, but the imaging depth, so how deep you can image, is determined by the tissue properties. So absorption and scattering properties are going to limit how deep you can look. And then the row on the bottom of the slide shows some some clinical systems. So these are actually systems that are used in the hospital these days to do measurements. So the first one on the left is a system for imaging the retina. So that has this headrest where the patient can put the head in and then have the retina imaged. The one next to that is for imaging the esophagus, the slokdarm. The one next to that is for imaging the aorta, so blood vessels. The one next to that is a kind of an experimental system that cannot be used directly into the clinic. We have to take some precautions, and that is then basically the photo that you see on the most right-hand side, where that system is packed into plastic and where still some imaging can occur. So why do we want to do this? Well, the main reason is again basically in this graph, because we can if we look at the different sizes of structures that we can encounter in tissue, then with visible wavelengths we are sensitive to a lot of them. So again, I've shown this graph before, I think. We are sensitive to wavelengths of about 8 wavelengths. That does not mean we can image structures of this size, but we can measure. We're sensitive to changes in these structures. So that basically means that we could already be sensitive to changes in nucleosomes or cell membranes or that size of changes. So if something changes due to disease or if something changes due to treatment, then at least in physical theory, we should be able to pick that up with an optical measurement. That is, of course, the main rationale. So if you now look at clinical applications of OCT, then there are a lot of them. So from top to bottom, again, we have the retina. We have let's say that's a blood vessel, and then after the bluish thing is a rendering of the esophagus. Then the one beneath that is skin, and the one beneath that I actually don't remember what it is, but these days there is a lot of clinical research going on in OCT. So there is a lot of medical fields where people are using OCT to image tissue and to measure properties from tissue. A little bit of the drawback from our field is that every researcher that tries to do that also invents his or her own acronym. So if you look in the literature, then you will find a lot of OCT acronyms that all basically use the same methodology. They just use the OCT signal as it is, maybe with some clever tricks, and then extract properties from that to do diagnosis. Actually, that field has grown so much that we have started joking that OCT is kind of like the Harlem oil of biomedical optics. If you have a problem in optics that you cannot solve, then if you would just add one drop of OCT to the measurements, then you would be able to solve it. So this really is the status of OCT in the broader field at this moment. Of course, that is only in the biomedical optics field. In the clinical field, there is still a lot of work to do, because we obviously would like to have it established as a routine used clinical technique. But we're not there yet. Okay, so let's brush up a little bit. This is on the left-hand side, a schematic of a Michelson interferometer, which is illuminated by a light source. That's the blue box from the left. Light is split by a beam splitter into two paths, going to two mirrors, bounced back from the mirrors, and then directed towards a detector. Depending on the positions of the mirrors, you can have constructive interference between the two waves from the two reflected from the two mirrors. So that is on the top. Constructive interference. You can have, and then skipping to the bottom, if they're completely out of phase, you can have destructive interference, and the signal will be completely zero. And you can have anything in between, which is basically the cartoon that is in between here. It is the path length difference, delta L, between both arms of the interferometer that determines what you will see in a measurement like this. So if I now would have one mirror moving, so let's say this laser emits only one wavelength, and if I would have one mirror moving back and moving back, then I could measure that interference signal as a function of the path length difference between the two arms of that interferometer. And I would measure the following. So if I have on the horizontal axis the path length differences, and on the vertical axis the interference signal that I would measure as a function of path length difference, then we'll see that we have constructive interference if the path length difference is exactly a multiple of the wavelength, so 1, 2, 3 times the wavelength, that is the peaks over here. We would have completely destructive interference when the path length difference is half times a wavelength, so the waves are completely out of phase, so half, 1.5 or 2.5 times the wavelength. And for example, if the path length difference is a quarter or 3/4 of the wavelength, then the interference pattern would damp out. So totally constructive, totally destructive, or damping out. Now that in itself is not so useful. This is just this basically is just a high school experiment where you would see an interference pattern. That is not so useful to do imaging because the signal basically repeats itself after just a wavelength. But if you add more wavelengths, if you add more colors, you can get more information because this condition holds for each wavelength. So the condition that there is constructive interference for a multiple of the wavelength holds for each wavelength that you send into this interferometer. It's a little bit hard to see, but there is a black and blue wavelength now in this graph, and exactly for path difference 0. And not even exactly if I look closely in the figure, but that should be for exactly path length difference 0. Both of these two should be constructively interfering, and for all other differences, it will depend on the wavelength. So again, let's take a monochromatic light source, so only one wavelength that illuminates this Michelson interferometer with one mirror moving. You would measure this interference signal as a function of mirror position. If I would add wavelengths in this laser, so more wavelengths, a quasi-monochromatic light source, I would see a pattern that is very similar. So I would still see a long interference pattern, but it will be maximized only around mirror position 0. And at any other mirror position, so let's say at mirror position 6 or so, some wavelengths are going to be completely in phase, but some are going to be completely out of phase, and they will cancel. So then in the end, the result is that the magnitude, the envelope, let's say, of this interference pattern will drop as the mirror position moves further away. So if I add even more wavelengths, and then we go to a broadband light source, so kind of white light, all the wavelengths are in there, then this pattern can become extremely narrow. So we can only, if there's a lot of wavelengths, then only for the condition where the mirror position in one of the arms, the reference arm, the moving one, is exactly the same as in the sample arm. If these lengths are exactly the same, the path length difference is exactly 0, only then will all these wavelengths interfere. And at any other position, some will interfere constructively, some will interfere destructively, some will cancel, whatever will happen, but the overall magnitude will drop. But only at the position of 0 delay, 0 difference, will all the wavelengths constructively interfere. And then you will have signal build. And so the takeaway from the previous 3 slides is that if you add more wavelengths to your laser, then this interference pattern will become narrower and narrower and narrower. And that is then what our measurements basically contains. We'll flip the script. We'll turn it around. We say, okay, if we see an interference pattern, and we know what the length of one of the arms is. That's the reason it's called a reference arm, because we use it for reference. If we know what the length of that reference arm is, then we can calculate what the length in the other arm is going to be, because only then there will be interference. But that is the basic concept of OCT. Was that clear, or is that? So the more wavelengths you put in your interferometer, the narrower your interference pattern is going to be. And then you flip it around. You say, okay, if I see an interference pattern, I know it is very narrow, and I know it only occurs when the distances between the two paths are exactly the same. So if I see it and I know one of the lengths, then I'm pretty sure what the length in the other one is going to be. And then I can assign a depth to that. And then I can then if I change the position of the other mirror, I can do the same measurement for the different depths, and that way I can build up an image. So if you now look at this, so the idea was that the more wavelengths, the broader the bandwidth of the broadband light source, the smaller this peak becomes. The width of this peak is called the coherence length. So formally, it is the full width at the half maximum. So if in this case the maximum is at about 150, then the half maximum is about 75. So you would measure the width in mirror positions at an amplitude of 75 to calculate this coherence length. If the spectrum is Gaussian shaped, so that's an idealized spectrum, then you can actually do this analytically, and then the formula is given here. So then the coherence length, the width of that peak, is 2 times the natural logarithm of 2 divided by pi, so that is just a constant, 0.44, I think, times lambda 0 squared, that is the center wavelength of the light source, and delta lambda, the bandwidth, the complete bandwidth of the light source. So these two determine what the resolution is going to be. That determines the width of that peak, that coherence length, and that determines how accurately you can determine a position in the sample once you know the position in the other arm. So I have two examples from two OCT examples here and an histopathology from the same type of tissue. This is a piece of esophageal tissue. The left-hand image was taken with an OCT system with a center wavelength of 800 nanometers and a bandwidth of 125 nanometers. Well, if you fill these numbers in the formula over here, you will see that the coherence length is 3 micrometers, which means that we can resolve positions in this image in depth with an accuracy of 3 micrometers, and that, yeah, so it looks kind of sharp. So that is okay. This is in the middle is then the same piece of tissue, but then measured with an OCT system operating at the center wavelength of 1300 nanometers, so farther into the near infrared, and a bandwidth of, let's say, only 50 nanometers. So again, filling in these numbers will give you a coherence length or an accuracy at which you can determine positions here of 15 micrometers, so 5 times as worse. And you can see that in the image quality. It is not as sharp. It is more granular than the picture on the left. On the other hand, and that is then a little bit harking back to the questions I asked you, you can see if you look at the scales, they are almost the same. It does appear that you can look a little bit deeper in the 1300 nanometer system, but that is a little bit up to in the eye of the beholder. And then we have histopathology, so that is just taking the piece of tissue and cutting it up, coloring it, and imaging it under a microscope, where you can get a resolution of about 1 micrometer. Of course, you see much more details there, but still some of the features like this blob here can be found in both images, both OCT images and the histopathology. All right. Then this was still old-fashioned time domain, where a mirror was moved and that was related to the position of a reflector in the sample. The faster and the more sensitive way of doing it is a spectral domain OCT. So where, as Manouk accurately said in the comments, where the mirror is not moving, that is fixed at a certain position. Yeah, you still use a spectrum with a lot of bandwidth, but now on the detector side, you use a prism or a grating to split that bandwidth of that laser into multiple subbands. Each of these subbands is detected with its own detector. So you put a CCD camera at the output of the prism, and you measure this spectrum. And what you will see is also again an interference pattern, but now not on a spatial domain signal, but the interference pattern will be on top of the spectrum. So you will actually recover simply just this spectrum, but then with the modulation on top of it. And it turns out that this modulation that is on top of it is proportional to the distance between the reflector here and the reflector there. So basically proportional to the blue part. Or to put that into graphical terms a little bit further even. So again, on the left hand side you have the interference of the interferometer with the spectrometer that measures this this spectrum, which has a modulation on it. If you take a Fourier transform, then this modulation will result in a shift on the distance axis, and the shift here, the blue shift here, will be proportional to the blue shift over here. So the path length difference between both arms, and the modulation frequency that is on top of the spectrum. So if I would have this mirror in the interferometer at a larger position, so the blue part basically would be larger in that interferometer, then the modulation on the spectrum would be larger, would be a sharper, finer modulation, and the peak here would have shifted to the right. So the modulation frequency on the spectrum is directly related to the distance between the reflector in one arm and the mirror in the other arm. So if you can resolve that modulation frequency using a Fourier transform, for example, then we can get the depth information back. And then again, the width of that peak is still related to the width of the optical spectrum. So it is still related to that coherence length. So again, again in summary, so you can measure distances. So let's say the blue part, you can measure distances with the resolution, the width of this peak. That is given. The resolution is given by the peak, is given by the coherence length of the light source, and then the coherence length is related to the full width at half maximum of the light source. All right. So what we like to do, what we want to do in our research, is get more from these measurements than just an image. And to illustrate that, this is again that system that images the retina, but now the output you see here is raw data. So there is no smoothing, no filtering, no nothing, and you can see a very wobbly appearance in there. Can you speculate what causes this appearance? And I'm going to give you a small hint. This taking this image took about 3 seconds.
Maybe the patient just couldn't sit still.
Yeah, absolutely. That's one. Yeah. Even if he could sit still, he or she could sit still. Well, they still breathe, and there is still a heartbeat. So what you see, so asking someone to sit still actually works quite well. So even within 3 seconds, so that would work. They can even hold their breath for 3 seconds, even if you consider that they are mostly older people. That still works. But the heartbeat is something that you can't just suppress. So what you see here is the heartbeat. So just I mean, this is not so totally clinically relevant, but it is nice that you can actually do this. So this the left-hand side graph shows an analysis of this OCT images. So the peaks then correspond to the peaks of that oscillation that you see in the image. And then we had a control on a finger that just measured the heartbeat using a pulse oximeter. And if you then make take a Fourier transform of both of these signals, you can see signals at a frequency of let's say 1 hertz, 2 hertz, 3 hertz, which corresponds to about 60 beats per minute, which is not so strange. And the same thing comes from the blood pressure measurement. So this oscillation was basically caused by the heartbeat. You can turn that around. You could ask yourself, okay, can we now measure the heartbeat from an OCT signal? That was not so interesting, so we did not pursue that any further. But the point is, you can get more information than just an image. You can get physiological information. Another example that illustrates that it's possible, but also that it's hard, is if we now take two layers within that retina. This is from that exact same image. If we take two layers and we calculate the average intensity as a function of depth, that is the black line you see here. Of course, the resolution of our system was not so great, so that is not a perfect peak, but it has a certain width. And now the question is, let's see if we can calculate the thickness of such a measurement. And then it turns out that different algorithms will give different values. Some systems have algorithms that find the maximums and calculate the difference between the maximums. That would give you a thickness of, in this case, what is it, 161 micrometer. There is also algorithms that would take let's say the maximum gradient, so that would give 180. And there is also algorithms that would just define a peak when the signal exceeds a certain threshold, which would give you 194. So in this case, that would give you a difference about 30 micrometer in the estimation of layer thickness. And if you are a doctor and you want to base a diagnosis on this layer thickness, then you have to be pretty sure which algorithm is in your system and which conclusion you make. So that's the caveat. So we want to have more information from our images, but we also have to be very, very careful to be sure what the algorithms is and explain what the algorithms are in order to get the right results out. Okay, so why do we want to do this? This is already an older report. It is about the prevalence of cancer in the Netherlands. It came out in 2011, so that is 9 years ago. And it predicted an increase of 40% in new cancer patients yearly. And not only that, because of the aging society, it also predicted that there will be 60% more patients living with cancer in this. Yeah, actually now, is what they predicted, and all these people, so the new cases, but also the people that already have it, will keep visiting the hospital for checkups, for diagnostic procedures, for treatments. So these numbers by itself presented a very huge increase in workload in the hospital, and not at that point. So we have to see how it stands now. But at that point, not a very good outlook. So the causes again are aging population. So people live longer just because people are healthier now. So the people stay longer alive with cancer, which is in essence a very good point. We also detect cancers earlier. That also means that we can treat earlier, which also improves prognostics. So that people live longer with that, and our treatments get more efficient. So that also means that people live longer. So in essence, this is all good news. But the only drawback is that the burden on the healthcare system is a little bit is a little bit hard. So how do you maintain what's then called the quality of the care cycle? So how can you maintain that people get the care that they deserve over that almost half a lifetime? And also it puts a little bit of pressure on the economic sustainability of the healthcare costs. So then, in order to tackle that, there has been a kind of a national effort actually to look at imaging techniques, to look at medical imaging techniques that can be used to basically to relieve this problem. So the problem was that in many cases they were not capable of differentiating benign and malignant lesions. So if a cancerous lesion, for example, becomes large enough, then you will be able to see it on MRI, on CT, or on any other technique, but you cannot, from the image alone, you cannot differentiate whether it's benign or malignant. So basically, that means that we still need biopsies to. So we still need to take out the tissue, put it under a microscope, and stain it chemically in order to see whether it is benign or malignant. And that is basically what takes most of the time in the care cycle now, because the patients have to come in, they have to undergo kind of a surgery, even non-invasive as it can be. They have to wait for the results come in, and etc. etc. So that is the part that we would like to center in. So can we now aim these diseases where you actually do not want to do a biopsy, for example, the vocal cord or the genital areas, and can we there improve? So why do you think we can do it? Well, if you look at the at how disease or let's say cancer progresses in optical terms, what we know from these biopsies is that there is a lot of structural changes going on as the tissue develops disease. So normal tissue would have a large cytoplasm in the cells, and a cancerous cell would have a small cytoplasm. Normal cells would have single nuclei per cell. Cancerous cells could have multiple nuclei. Also for nucleoli, also for mitochondria, there's going to be a lot of intracellular changes already when cancer develops. And the reason for that is that the cancer cell is very impatient. It wants to grow, and it basically pays little attention to its development. So there is a lot of sloppy architecture, sloppy cells that occur. You can see that in the examples here, for oncocytoma, which is a benign renal kidney disease, and the other one is clear renal cell carcinoma. You see a very different. This is just a small section, but you see the very different appearance in where the nuclei are, the black dots, how the density of the coloration is, which relates to cell membranes. So there's a lot of difference over there. So what we hypothesize, what we want to do, is to use this change in physiology and translate that into quantifiable changes in optical spectra, in optical properties. If we can measure these, then hopefully we can relate that back to the state of disease. And that basically means that we want to do an OCT measurement and then try to extract the familiar optical properties. So the absorption coefficient, the scattering coefficient, the scattering anisotropy, maybe other parameters of the phase function. So all the things that you have seen before is what we'll try to extract. So specifically for cancer, there are two important diagnostic factors, prognostic factors. One is stage, which is the invasiveness of the lesion. So that basically relates to ingrowth, how far the cancerous lesion has grown into the tissue. And that should be something that you can identify with imaging. And the other one is grade, that is the aggressiveness. And that one actually relates to the changes in morphology that I tried to show in the previous slide. So with imaging, I think we should be able to measure stage. For grading, we would need to actually extract optical properties from these OCT slides. I'm going to skip briefly through the next couple of slides because Martijn has a much more compelling story to tell. But this one I still need. In order to do that, to extract these optical properties quantitatively, we need to look at image formation. We need to quantify how an OCT image is performed. So for the lateral resolution, so that is not a resolution in depth, but a resolution in the plane, the idea is that it works more or less just like confocal microscopy. So you have a lens, and the lens focuses the light onto a certain spot size. And if you have a strong lens, it will be a smaller spot size. If you have a weak lens, it will be a larger spot size. So that will determine your resolution. For the axial resolution, it is a little bit different. If you have an old-fashioned time domain OCT system, you would have the reference mirror move. That is the one on top there, to obtain your image, and you could and your measurement point would scan through the tissue just like that. For these faster, more sensitive spectral domain OCT systems, the reference mirror is fixed, and then then it's difficult to do that assessment. So you would have to look into the image formation of light going into and coming from the tissue. So if you look at the cartoon that is on the top of the on the bottom of the image, you have from the left you have a fiber. Light is emerging from the fiber, hits a lens. Then there is the light is collimated, parallelized, and then hits another lens, and then a focus is made somewhere inside the tissue. Now, somewhere inside the tissue, the light is reflected back through that same lens, through that same second lens, and back into that same fiber. That's how the OCT system works. So that's basically the right-hand side of this cartoon. But if that geometry is not quite aligned, for example, because the lenses are not quite aligned, or the scattering is not in the right direction, or because the scatterer does occurs at a certain depth delta away from the focus point, then you will get a different result. You will get a different signal, and that we can calculate. That so what you see in this in this graph here is the signal that you would get if you would have an OCT beam that has a focus somewhere here, and then a particle, small spherical particle, somewhere here at a distance d from the focus point, and in depth, and a distance x from the focus point in the other direction. And you can calculate what signal you would measure as a function of the position d and x of that particle. So if the particle is completely in the focus, so completely sharp, completely helemaal scherp opgenomen, then you would have the maximum. And if it's anywhere else, then you would get a result, and you would measure something that is less. That's too bad, but the good thing is that if you know this formula, and if you can calculate parameters in this formula, you can account for that. So then you can just, if you measure something that is at a different location, you can use this formula to account for that. Okay, I'm going to skip over this. Last part for that, and that relates purely to spectral domain OCT. There were many great advantages of using this spectral domain. You could go faster, you would be more sensitive. There is one big trade-off. The depth at which you can image is going to be limited. So there is going to be a maximum imaging depth. You can calculate that as well. That is lambda 0. That is again the central wavelength of the light source divided by 4 times, and then small delta lambda. So not the delta lambda that we had in previous equations, but this is like a small delta lambda. So it's not the total bandwidth, but it's the bandwidth of a single pixel at your spectrometer. So basically, we have an inversely proportional relation again. If you can build a spectrometer which has infinitely small pictures, you could measure infinitely deep. But if you in real life, your pixels on your spectrometer, just a CCD camera, just like in your phone, they will have finite pixel sizes, and the result of that is that you will only see up into a certain depth, Z max. Again, this one too, and I can't help it. I'm going to show you the equation anyway. Martijn is going to show you all of this, so that's not important. So that equation you can make as well. You see it over here. So it's an ugly equation, but there is again, as long as you can calibrate these things in forehand, then you can account for all the effects that all the imaging effects that are in the system. And if you can do that, you can correct your signals, you can calibrate your signals, and you can actually try to estimate the optical properties from the OST image, and from the optical properties, hopefully, the state of disease. All right, I'm going to stop here. Martijn is going to continue. Let's take a 15-minute break, and then he will talk you through the real clinical stuff. Of course, if there's any questions, then let me know.